All right. So drugs interact with other drugs, food, and supplements at each stage of their pharmacokinetics interactions, which could be at the site of absorption, distribution, metabolism, or elimination. Drug absorption interactions can involve two drugs or a drug and a food product. When administering together, these interactions limit the ability of the drug to cross the membrane, the mucous membranes in the stomach and the small intestines, and eventually reducing its blood levels and effectiveness. An example of this interaction would be the antifungal agent ketoconazole. This antifungal is absorbed at highly acidic pH. So antacids, histamine 2 receptor blockers, like cimetidine and ranitidine, and proton pump inhibitors like omeprazole, all these can significantly reduce the absorption and antifungal efficacy of this drug. Next, we've got the drug distribution interactions. Following the absorption into the bloodstream, most drugs exhibit varying degrees of plasma protein binding. That is, that they reversibly bind to albumin and other plasma proteins. Clinically significant interactions can occur when two highly protein-bound drugs are given together and they compete for these sites. So an example of this would be like warfarin and NSAIDs. Both warfarin and ibuprofen are highly protein-bound, and prescribing ibuprofen to these patients could alter the warfarin's protein binding, increasing the free blood levels and also greatly increasing the chance of bleeding episodes. The liver is a major site of drug metabolism, and the major metabolizing family of enzymes would be the CYP450 family. In the biotransformation group of interactions, the metabolism of drugs is altered through enzyme inducers and enzyme inhibitors. The enzyme inducers, for example, like carbamazepine and alcohol, these will increase the rate of metabolism and decrease the bioavailability of drugs. While enzyme inhibitors like erythromycin and enzyme inhibitors like erythromycin, metronidazole, and grapefruit juice, these will decrease the rate of metabolism of certain drugs and cause toxicity. An example would be the ability of erythromycin to reduce the metabolism of theophylline, which is a drug taken by asthmatic patients, and this can lead to arrhythmias, tremors, and seizures. When talking about the drug excretion interactions, the kidney would be the primary organ of drug elimination. And the ability of one drug to impair the renal elimination of another drug can result in supratherapeutic blood levels of the drug being retained. Basically, kind of like an overdose of the drug. Non-steroidal anti-inflammatory drugs, including ibuprofen, diclofenac, and naproxen, these all have the ability to inhibit the renal excretion of lithium, which is a drug that has a very low therapeutic index and can lead to severe central nervous system and renal toxicity. Up next, we have the pharmacodynamic interactions. These interactions occur at the site of drug action, which is more specifically at the extra and intracellular receptor levels. These complex interactions can be explained as additive, where two drugs combine to potentiate either or both actions, A well-known example of this would be the additive effects of combining narcotic analgesics with alcohol. These two central nervous system depressants, they can occupy these receptors in the brain at the same time. Synergistic interactions, these will cause an amplification of the intended therapeutic effect of the drug. An example of this would be the supraadditive interaction at distinct receptors between NSAIDs and selective serotonin reuptake inhibitors. These both will cause GI bleeding. Antagonistic interactions, just like additive or supraadditive interactions, you can also have an antagonistic or opposing interaction, which can occur between two drugs that occupy pharmacologically identical or dissimilar receptors. The ultimate effect will therefore be reduced activity of one of the interacting drugs. So now I will basically go over this article just to give a brief examples of the different drugs that we use in the dental office. Starting with antibiotics and antifungals, we have certain antibiotics can significantly increase the blood concentrations, half-life, and the associated hemorrhagic potential of anticoagulants like warfarin. So before prescribing any of these antibiotics to dental patients on chronic warfarin therapy, consultation with the prescribing physician is always recommended. The macrolide antibiotics, erythromycin and clarithromycin, are potent CYP3A4 isoenzyme inhibitors. And the ability of these drugs to inhibit the metabolism of other CYP3A4 substrates is not only clinically significant, but it has led to some cases to be life-threatening outcomes, usually as a result of an extension of the drug substrate therapeutic and toxic effects. An example of this would be an asthmatic patients taking theophylline. Erythromycin basically inhibits the metabolism of this medication, leading to toxic serum levels. Clarithromycin and erythromycin both should be avoided in patients with congestive heart failure who are on digoxin therapy. These antibiotics inhibit the extrusion of the digoxin from the bloodstream into the intestinal lumen or renal tubular system, leading to rapid rise in digoxin blood levels, resulting in classic digitalis toxicity. It's always recommended that the levels of digoxin should be monitored during any antimicrobial therapy. Next, I'll be giving some examples of analgesics used in the dental office. Hepatotoxicity is a complication of both chronic alcohol use and the acute overdose of acetaminophen. In addition to being the most widely used and sold over-the-counter analgesic, the maximum daily dose of acetaminophen should not exceed 4,000 milligrams, and patients should be encouraged to limit the consumption of alcohol when used together. Also, when speaking about acetaminophen, when it's used together with warfarin, the risk of bleeding may increase if higher dosages of acetaminophen are used for a week or more at a time, especially in individuals who are elderly, consume alcohol regularly, or have poor nutrition. Non-steroidal anti-inflammatory drugs are commonly prescribed or recommended by dentists, and the combined use of alcohol and NSAIDs significantly increases the risk of GI blood loss associated with GI erosions and ulcers. Not only are Both alcohol and NSAIDs are capable of damaging the GI mucosa, but also alcohol may stimulate the gastric acid secretions, aggravating the GI toxicity of the NSAIDs drugs. It has been recommended that aspirin and alcohol consumption should be separated by at least 12 hours. The combined use of anticoagulants and NSAIDs is generally discouraged because of the increased risk of bleeding also. Prescribing NSAIDs should also be avoided in patients that have a higher risk of bleeding and peptic ulcers. The presence of high concentrations of NSAIDs in patients with slow elimination of anticoagulants, like, for example, those with severe heart failure or impaired liver function, this can induce GI bleeding, which is most likely to be way more severe if the patient is also taking anticoagulants. NSAIDs have the potential to exacerbate pre-existing hypertension and increase the mean arterial pressure in susceptible patients. The hypotensive effect of the calcium channel blockers or the ACE inhibitors or beta blockers and all the medications taken by these patients, they're all antagonized by the use of NSAIDs. Therefore, limiting the duration of NSAID dosage to 4 days is recommended. Now, talking about methotrexate, it's a drug administered at relatively high doses in the treatment of cancer, and it has the potential side effects of thrombocytopenia, neutropenia, renal failure, mucositis, and it has a lot of side effects. And at a lower dose, it is used for the treatment of rheumatoid arthritis and other conditions requiring immunosuppression. So in this case, with the high dose of methotrexate therapy, simultaneous NSAID therapy increases the risk of serious side effects. So the clinicians should be careful when prescribing these NSAIDs for postoperative pain and or those that are already taking NSAIDs for any arthritic conditions. Up next, we have the local anesthetics. Antihypertensive medications are one of the most commonly prescribed in primary care. And the most common drugs administered by a dental practitioner that could affect these antihypertensive agents are the local anesthetics containing epinephrine. So the epinephrine binds to the alpha receptors in the peripheral vasculature, causing vasoconstriction, along with an increased heart rate due to binding with beta-1 adrenergic receptors on the heart wall. So therefore, the overall reaction could be potentially dangerous in increasing the heart rate and associated peripheral vasoconstriction, leading to an increased blood pressure with potentially harmful consequences. So when administering these local anesthetics, it is recommended to monitor the patient's vital signs, provide a 5-minute interval between the first and second carpules with continual monitoring. Tricyclic antidepressants. These are probably the most commonly prescribed medications for depression. They work by blocking the reuptake of noradrenaline at the central synapses, and this causes an elevation of the concentrations of noradrenaline also the tricyclic antidepressants at the level of the neurons. So further administration of adrenaline-containing local anesthetics, this could have a significant effect on the cardiovascular system, leading to cardiac arrhythmias and hypertension. So again, it's important to monitor the patient's vital signs, and also to limit the dose to 2 carpules containing 1 to 100,000 epinephrine. So in conclusion, I just wanted to say that oral health professionals should carefully review the patient's medical and drug histories, paying particular attention to the prescribed and over-the-counter agents and herbal supplements. This is especially important when new medications are prescribed or recommended as part of dental treatment to ensure the safety and effectiveness of all drugs taken by the patients. And that's it.
Thank you so much, Dr. Fatima. So if there are any questions, Dr. Hassan and Dr. Jordan Prince are finishing up with their last sedation patient at Westford office, and they will be joining momentarily. Meanwhile, you can write your questions in the chat for them to answer. And you can also review the PDF if you had any, take the chance to review the PDF and kind of refresh the memory, and we'll take the questions soon.
And Dr. Sally. Today I'll be presenting a refresher on coronary artery disease and atrial fibrillation, and then at the very end discussing how it ties into dental management. So these two topics, there's so much information, so I'm trying to be as concise as possible, so bear with me. All right, so we're going to start off with coronary artery disease. So what that is narrowing or blockage of the coronary arteries that supply oxygen and blood to the heart. It's the most common type of heart disease, and it's caused by atherosclerosis, which is a buildup of cholesterol and fatty deposits inside the artery, so it narrows it over time. And it limits the blood supply to the heart muscle. And the plaque can rupture and lead to thrombosis formation. So this is a schematic showing how it is caused. So this increases the risk for high blood pressure and angina pectoris, shortness of breath, heart attack, and stroke. There are two main types of plaque, hard and soft, that contribute to the blockage of the artery. The hard ones cause chest pain by diminishing or stopping the flow of oxygen-rich blood to the heart muscle. If it totally obstructs the coronary arteries, then a heart attack can occur. The soft ones can lead to formation of a blood clot, which can cut off the blood supply to the heart and trigger a heart attack. A blood clot that restricts the heart's blood supply can cause permanent heart damage to the patient. So the risk factors. Risk factors include smoking. So basically nicotine narrows the blood vessels, and carbon monoxide can damage the inner lining, making them susceptible to atherosclerosis. High blood pressure. So if you have uncontrolled high blood pressure, then that can lead to hardening or thickening of the arteries, and it narrows the blood vessels. High cholesterol levels or lipoproteins. So when we have an increased level of that, then again, we have an increased risk of the plaques forming in the coronary arteries. Other risk factors include diabetes, obesity, sedentary lifestyle, family history, and age. So the signs and symptoms. So patients with this usually exhibit asymptomatic earlier on until the plaques grow more and more. Then they can have stable angina. So with activity, they have chest pain and shortness of breath, or they can have unstable angina where even when they're not doing any activity or just through rest, they can have chest pain. Fatigue is another sign and symptom. So diagnosing, medical history, assessing the patient's medical history and assessing their risk factors. So for example, that's why in our dental charts, we always ask for family history of heart disease, because there's a correlation, physical exams, so cap refill testing, clubbing fingers, checking the skin color of the patient, swelling of extremities or the legs, blood tests for checking for lipoprotein profiles, the levels of LDL, HDL. There's also a stress test that you can do. So it monitors the electrical activity of the heart while the patient is walking on a treadmill or a stationary bike. And it can see how the heart responds to increasing exercise. Electrocardiogram and a exercise thallium test. So similar kind of concept where there's a radioactive substance that is injected into the bloodstream. So when the patient exercises, you can detect where the blood flow is moving around in the arteries and where it's restricted. A Holter monitor, so a patient can wear a portable ECG monitor for 24 hours, and you can see how the heart is functions throughout the day, and also cardiac catheterization or angiogram. Management. So patients with coronary artery disease, usually the medication is lifestyle, so trying to quit smoking, increasing your exercise, losing weight, avoiding high cholesterol foods, trying to reduce and manage stress, or they can be prescribed medications by their GP, so blood thinners like aspirin or warfarin, antiplatelets like aspirin, anti-anginal agents, so nitroglycerin, calcium channel blockers, ACE inhibitors, or statins. Statins is for controlling their cholesterol levels. Others, if those don't work, then patients may need surgery, so coronary artery bypass surgeries or balloon angioplasty and stent placement. And the next we'll be talking about atrial fibrillation. So what this is that normally our heart contracts and relaxes in a normal coordinated beat, but in atrial fibrillation, the upper chambers or the atria beat irregularly, and this ineffectively moves the blood into the ventricles. So a heart rate in atrial fibrillation may range from 100 to 175 beats a minute, where normally it would be 60 to 100 beats a minute. The biggest concern with atrial fibrillation is the potential to develop blood clots within the upper chambers, which occurs when there's blood pooling in there. So these blood clots forming in the heart can circulate to other organs, such as your brain, and lead to blocked blood flow and stroke. So patients with atrial fibrillation are 5 times more likely to have a stroke. Risk factors are very similar to CAD, but the biggest one is age. So age over 60 has been shown to be related to age-related fibrosis of the heart, high blood pressure, diabetes, again, past history of heart disease or family history, and other conditions as well, such as if you have a history of lung disease or thyroid disease, smoking, and endurance sports. So with atrial fibrillation, there are some triggers that can create an onset of atrial fibrillation, so such as fatigue and sleep deprivation. Serious illness has been a big one. Stress, hormonal fluctuations, exercise, alcohol consumption, dehydration, recreational drugs, and certain foods and beverages that the patients themselves monitor. So usually the signs and symptoms, what patients may describe is that they feel that their heartbeat is really fast or racing, or it's skipping and flip-flopping in their chest. They may have chest pain, shortness of breath, they may be tired, or they may just be completely asymptomatic. So there's different, So there's different types of atrial fibrillation. So the condition can get worse over time, and so early detection is key. The longer the heartbeat is out of the rhythm, the harder it is to bring the heart back to normal. So if you can see in this schematic here, the blue is the normal, when the heart is in normal rhythm. So the time elapsed when your heart is in normal rhythm. And the red is AFib, or when it's abnormal. So you can see here, paroxysmal AFib is periods of AFibs that come and go, and they can be momentarily or last for days or weeks, and generally they can go away on its own. If that isn't detected and treated, then it can lead to persistent AFib. This is when it cannot go away on its own, and you may need medications or procedures done by a doctor to bring the heart back to normal rhythm. And then the longer, the more severe case is the permanent AFib, where the heart is now unable to return to normal rhythm. So without treatment, it's also important to address that it can cause heart remodeling, which means that AFib can change the shape and the size of the heart. Diagnosis, very similar to CAD. The most important though is the ECG. So the small electrodes are attached to your chest and arms that records the electrical signals as they go travel through the heart. This is the primary tool for diagnosing atrial fibrillation. Other ones, such as medical history, physical exam, blood tests, stress tests, etc. Major is just to figure out why that happened in the first place, why this is occurring, or discluding any other heart conditions that could be associated as well. So here's a schematic of a EKG that you would see. So this here is the normal rhythm. You could see the PQRS rhythm. It's evenly spaced, whereas in AFib, it's quite erratic compared to the isoelectric line. The management. So the goal for a management of AFib is to reset the rhythm or control the rate, and to prevent blood clots, because you want to decrease the risk of stroke. So medications, for example, doctors will prescribe rhythm control drugs or rate control medications, anticoagulants or blood thinners to prevent any clots from causing a stroke. Cardioversion, so this is when electrical current is used to restore normal heart rhythm. This is usually used in the early stages. There's also catheter ablation, so they use a probe to zap where the faulty signals are with radio frequency. More invasive procedures they would undergo is surgical ablation, so a surgical procedure to destroy the cells that are causing the abnormal heart rhythms. And then the atrial pacemaker, which is like a device that's implanted underneath the skin to generate the electrical signals to regulate the heartbeat. So why does this matter to us? Because the heart and oral health are connected. And a lot of times patients themselves don't know this. So reviewing medical history and a physical examination is key. The reason why is in medical history, a patient may not even write it down because they think that it's not relevant to their oral health. So it's important to ask them yourself what medication they're taking, their signs and symptoms. Physical examination as well. Sometimes they are asymptomatic and they don't know that they have these conditions. So physical examinations such as assessing their skin color or the swelling of feet and legs, cupping fingers, or capillary nail refill test. You can test and see if there's any abnormalities. This I learned from shadowing Dr. Hassan. It's actually a really useful tool. Other things, if you know that the patient has had myocardial infarction, stent placement, or coronary artery bypass surgery, you should defer any elective treatment for 3 months. If you see that the patient is taking any antiplatelet drugs, such as aspirin or anticoagulant warfarin drugs, make sure to communicate to the patient that there's an increased risk of bleeding. Other than that, they shouldn't be seized because the risk of thromboembolism is higher than the risk of bleeding. So the bleeding can just be managed with local measures such as adrenaline-containing LA, insertion of resorbable PEC, and suturing. With warfarin, make sure that you organize a blood test for your INR, which should be done 24 hours beforehand. 2.2 to 4 is normal. If it's greater than 4, you should consult the GP. Also, blood pressure monitoring is key. Like I said, a lot of people with hypertension do not know that they have it. And a lot of the times, patients go to their dentist more times than their doctor. So a lot of the times it's actually the dentist that diagnose hypertension. We know that severe long-standing pain can increase blood pressure. We also know that severe anxiety associated with dental phobia can also increase hypertension. So taking into that into account, we should do shorter appointments, relaxation techniques, and consider sedation for those patients. In terms of blood pressure monitoring, the current guidelines state that if it's 160 to 100 systolic diastolic, and it's elective treatment, you should, yes, 160 to 100 or higher, we should refer to GP if it's elective. But if it's an emergency, and as I said, we know that the pain can increase the blood pressure, we can proceed with blood pressure monitoring every 10 to 15 minutes and anxiety reduction techniques. If, however, it's greater than 180 to 110, then there should be GP consultation before initiating any treatment. One of the main things for this is to be prepared for any medical emergencies. So our time to react to these conditions and noticing what the signs and symptoms are for these conditions are, for a medical emergency, sorry, are key. The other thing is that Fatima had talked about already earlier is to minimize epinephrine in LA with people with hypertension, for example, CAD, like Fatima had mentioned. Yeah, that's it. Thank you so much, everyone. I hope I didn't bore you.
Thank you very much, Dr. Ahmed. You know what, why don't we go through a review of your lecture before we open the door for people question. Do you mind if you go to slide number 2? I think you've done a great job, but I think that let's review some of the things that probably was supposed to. So you've mentioned the clogs, right? So at what point of blockage will you start to see symptoms? So it's usually 50 to 70%, right? So this is why this is a silent killer. So you can actually start to get clogged. And you have a very nice drawing over there. And if you look at the fourth circle and you see there is different things, right? So what usually happen is that the bottom one, whereas the usual is the light brown is, let's just think this is the plaque, okay? The plaque, and if we try to remember ourselves something called, the Verkos triad. The Verkos triad are three things, right? So there is injuries, the endothelial cells layer of the blood vessels. That's number one. Number two is stasis. And number three is hypercognitive status. So over here, if you look, you will see that you have a little bit of a clog. Let's just say that on the third circle, probably less than 50, so you might not. But you know what the problem is that if a thrombus, like the top one, right, start to accumulate into it, right, for any reason, right? So if the first one, which is a very small plaque, get dislodged for any reason and moves around to a coronary artery and injures the endothelial, you're going to get a thrombus that's going to close it and block it. Now, this is very important for us to realize because you know what it is? The patient probably wouldn't have any symptoms, but they know it is. Now, if we're talking about the symptoms, it's going to manifest itself as angina. So how many types of angina? You've mentioned stable and non-stable, correct?
Yes.
Now, there is a third one. What's the third one called? So it's called Prince metal, and it affects up young females, right? Usually, it can affect anybody, but usually the trend or the most common population are young females, usually happens in the morning, and it's due to vasospasm. So imagine, here's how it is. I have a female who is 20 years old, that is very depressed, that it's obese and she overeats, and her high cholesterol levels, and she has that. And on the top of that, she gets vasospasm. So she gets the best of the both worlds, right? She has the vasospasm, and at the same time, she will have the blood clot, and she will have the plaque as well. So that's an increased risk, right? So we need to be aware of this. Can you go to slide number 3, please? Right. So remember that there is always a lot of, one blockage of one of the arteries is not going to cause you an immediate heart attack. Okay, it's not, because remember, the heart has multiple arteries, right? So one blockage is not going to give you a heart attack. Well, I mean, in the sense of a heart attack that might kill you, but it might give you a little bit of a small. Now, another thing that I want you to go at is the progression. So you've looked into hyperlipidemia that has led to angina. Now, what would happen if a patient does not treat the unstable angina? Patient will go into a myocardial infarction. Can you please elaborate on the myocardial infarction for me?
So it's a lack of oxygen to your heart?
Right. That can, cause the infarction. You know what infarction means? It's literally death cell, right? So it's death, right? So, but, I mean, there is different types of myocardial infarction, right?
Yes.
So there's two types. The common, there's a STEMI and non-STEMI, right? And you've elaborated very well on this, and you said when you diagnose it, you put the patient on a monitor. So STEMI stands for ST elevation, right? You know the QPRS complex that you've mentioned to us?
Yes.
All right. So you will see usually an ST elevation. Does that mean that if you don't see an ST elevation, the patient is not going through a myocardial infarction? No, right? Because he can have an unSTEMI, right? Right. And you can have an ST depression, which is the beginning of, right? So this is something that we need to be aware of, right? Or we can have even an inverted P, right? So these are things that we need to be aware of. I'm not asking you to, but you familiarize yourself with the terminology. The reason why we are pressuring this right now is that as you may start to find out, medical doctors right now, according to their college, might come back to us when we send them the detailed questionnaire that we always give and say, you know what, we are not obliged to fill it up for you. Here is a copy of the patient chart. You make your own decision. So it's very important for us to know that. Now, is there any, you've mentioned, if you can go over it. Now, once you go into myocardial infarction, you have to remember that the STEMI usually is treated with, treated with usually a stent, right? And usually there is something called interaction very fast, so do not hesitate. So there is usually, why we're saying that, imagine, God forbidden, somebody have a non-stable angina, that means he's gonna progress. So they say there is a 90 minutes window from the moment that the patient goes into the hospital to the patient get a stent. So it's really very important for us to realize that the chances of survival, right, if we catch this within the first 90 minutes and the intervention done within the 90 minutes is extreme. That's why it's important. The studies have shown that patients who get intervention within 90 minutes will have a high survival rate, right? Versus if we got to mess around, see what's going on, all that stuff, right? So this is what it is. Now, on the other hand, the medications that we give for the patient is of importance to us, right? So I have to think, if I'm going to treat somebody who suffers from a cardiovascular disease, is there anything that I need to take in consideration apart from the blood thinners? How about local anesthetic? Do you think I can give them any local anesthetic?
You can, but there's a limitation.
Right. So what's the limitation that we have?
0.04 milligram for epinephrine, and
right, which translates to usually a couple of carpules on our traditional 1 in 100,000 epinephrine, right? So this is about a couple of carpules, right? Does that mean that people sometimes don't exceed it? Yeah, they do, but you have to proceed up with caution, right? Because at the end of the day, the last thing that you want to do is to inflict pain where your body is going to produce indigenous epinephrine versus, the 1 in 100,000 that you can introduce to the patient, right? And we all know where that number has come. It's come from the, calculation of epinephrine release in your body over daily activities. So if your patient can actually walk, a couple of flights, couple of blocks, city blocks, or, climb up a flight of stairs, this is the amount of epinephrine his body is going to produce. Now, let's stay within that mind. Imagine you are in Timbuktu. There's no medical doctor. You looked at beautiful things. You've mentioned up the nails. You've mentioned the cap refill. You looked at the ankle swelling, right? You look at all that stuff and the blood pressure. But what type of question? So this is your examination. So you're going to reach a diagnosis by 3 things, which is history, examination, and special investigations, right? So you've done the examination, but what about your history? What sort of questions do you ask in history?
You have shortness of breath or during times of...
Right. So it's called it's called up the, the questionnaire of daily activities, right? So what do you have a lot of pillows? Do you require a lot of pillows when you sleep? When you walk a city block, are you okay? Are you able to do daily exercises? Can you exercise, right? Are you okay, not just exercise, but to do an extreme sport like biking, right? Or something like that. And that will give you an idea how fit the person is and how good he is to treatment that we are going to give. And with regards to your blood thinners, when you are going to give antiplatelets, you're absolutely correct. I mean, you're going to give up something like aspirin or Plavix, right? And how do you measure your aspirin? Like, which test are you, if we assume that the patient has taken aspirin and for any funny reason, the patient's going to have an ablative surgery, not just like a regular tooth extraction, what type of a test for the sake of, completion, what type of test do you ask the patient to perform? Like what type of test do you require?
The platelet count, PTT?
No, I think we do bleeding time, right? We do bleeding time. And you know what's the bleeding time? What's the normal bleeding time in adults, healthy adults? It's 2 to 8 minutes. It's 2 to 8 minutes. So usually the normal bleeding time is 2 to 8 minutes in normal adults, right? And it's something good. It's something good for us to know, right? It's just like, I usually tell my patients, you might bleed a little bit more, right? But the bleeding is normal, and its advantages, risks, and benefit, which is more important. And as you said yourself, some local measures. So what are the local measures that you can prescribe at your disposal that can control up the bleeding?
So pressure by gauze,
Yeah,
resorbable pack,
right.
healing.
You got suturing, you have, you have pressure from the inside, pressure from the outside, as we always say. So pressure on the gauze from the inside, ice pack from the outside, right? That works. What else as well? What type of agents you can let the patients rinse their mouth with, you think that will actually help the clot?
Hexanamic acid.
Absolutely. How are you going to prescribe it? It's the right answer. But guess what? It's not as good as you know how you're going to prescribe it. You're going to give me amoxicillin, but I don't know how to prescribe amoxicillin. It's not good. How are you going to prescribe it as a mouthwash? Because that's what I want you to do it. I don't want you to do it as tablets, obviously. So how can you do it as a mouthwash?
So with the mouthwash is 10 millimeters rinsed in the mouth for 2 minutes, 4 times daily for 2 to 5 days.
Right. What's the concentration?
4.8%.
Absolutely, which is 5%. I usually write down for 4.8. I think it's in England or the States. In Canada, I think they come to concentration at 5%. So I just write it TA, mouthwash, 5%, dispense 1 bottle. Rinse your mouth with 15 ml, not 10 ml, 15 ml, like, you know what I mean? It's like, 3 teaspoons, right? It's good enough for the patient to rinse their mouth with it. 10 ml, it wouldn't be good enough. Right? So 15 ml, and you can do 4 times a day, you're at 5 times a day, it doesn't really matter, right? Because you rinse and spit, right? And that's good.
Sorry, do you also recommend the trexanamic during the procedure, irrigating the sockets with trexanamic acid?
Right. There is people who suggest that. You're absolutely correct. But at the end of the day, no. Because whenever you have a socket, I don't want to do that. Some people actually get a capsule and they crush it and they mix it up with a sponge and they put it inside. You know what it is? All those things, if we are going to ever discuss a dry socket, you'll find that there has been an association with an increased risk of a dry socket, right? So there is no point. Let's just say simple and simplicity. Less is more here. Less is more. Now, I want to move forward a little bit with AFib, right? So beautiful. You've mentioned something about AFib, which is the age, which is the hypothyroidism, right? Now, what type of drugs do we usually give for those patients? So when you say blood thinners, what type of blood thinners do we give?
Like aspirin?
For AFib, I wouldn't give aspirin, right? Because you have to think about it, right? So when you have a coronary artery disease, you have a clog, but there's nothing wrong with your blood, right? Because the blood is just normally going, right? The flow of the blood is normally going. But what you want the blood to be strong so it can just flushes out everything, correct?
Mm-hmm.
So that's why you want the blood not to stop, right? So that's why you want to thin it, correct?
Yes.
Do you understand what I'm trying to say? Right. Because if there is any injuries to the blood vessels wall, usually what happens, if you remember, if we ever discussed that we're gonna start up the primary hemostasis, right? But over here, it's not the primary hemostasis that we worried about, it's the secondary hemostasis, because the blood is not going in the normal fashion from a place to a place, correct? So usually what type of blood thinners would you give?
So then something that dissolves the blood clots then.
Right, anticoagulants, right? So something like what?
Heparin?
Right, heparin, but would you give heparin? Do you think the medical doctor will give heparin?
I'm not sure which one they
No, they wouldn't give heparin. They will give something else. What would they give? Heparin usually in hospitals, right? So what would you give? You will give Coumadin, right? Coumadin, right? Right? Well, don't get me wrong. Your answer of heparin is not wrong, but nobody, those are reserved for hospital patients, in-house patients, right? Hospital patients, rather than Coumadin, which is patients take up as a tablet, right?
Okay.
Right. So Coumadin works on which factors?
Vitamin K.
Vitamin K dependent factors, which are 2, 7, 9, 10. 2, 7, 9, 10, right? 2 plus 7 equals 9. What comes after 9 is 10. So 2, 7, 9, 10 is very important, okay? Because guess what? If we have a patient that is on Coumadin and he never told you that because we never asked, right? And it wasn't mentioning on the form, and you know, it's not the patients that mentioned, and we took a proper history, but we forgot to ask that to the patient. And then this is what happened. How can you reverse it? You will give vitamin K, right? You will give vitamin K. So it's good for us to know that. Not like we are going to do it, but if you are, for any other reason in the world, if we have a case of war and you end up in a hospital, working in a hospital, you remember that part, okay? So we'll give vitamin K. Now, imagine if the patient is doing this. So you've mentioned that, and I'm gonna start to mix it up a little bit with the other lecture that is gonna be done. So imagine is the patient is taking this blood thinner, right? The Coumadin, right? Is there any type of drugs that you want to avoid giving to him? Here we go. Let's just move to the other lecture about drug interactions. So is there any drugs that you want to avoid giving somebody who's taking Coumadin?
Yes, but I can't remember.
All right. So we okay. So let's just think about it from this perspective. So what is common antibiotic? So what do we give? We usually give antibiotics, right? Right? Do we give antibiotics? So we do. Do we want to give metronidazole to it? Metronidazole?
Rarely.
Right. You don't want to give metronidazole to a patient who has taken Coumadin, right? Because his INR will shoot up the skies to 6 or something, right? And that's not good at all. You wouldn't be able to suture him, right? Because he will just be dissolving within your hands, right? So you truly wouldn't do that, correct? But you have to think about it. So let's just remind ourselves, the patient or AFib, what do we say? Age. So age means partially or completely edentulous, correct? Mainly, most of the time, not judging, not generalizing, but mainly could be, correct?
Mm-hmm.
So if the patient's wearing a denture, he could be coming to you for what? Fungal? Fungal? So do you want to give antifungals?
Not with Coumadin?
Right. Not with Coumadin. There's actually a case of death. There was a case of death reported like this in England, as a matter of fact, and it was even published. So we really need to know about these things because these are the common things. The risk is real. I personally treated a patient that he wouldn't stop clotting, and we had an INR for him, and his INR was 2.5, and we just saying, what the hell? Why is he, right? Because if you think about it, why would somebody change an INR? His medication is the same, and his INR 2 days ago was 2.5. Guess what? He went up to his medical doctor, and his medical doctor gave him metronidazole, and when we measured in-house, the INR, that was obviously New York, not here, his INR was 6. And he couldn't stop bleeding. He carried on bleeding, and bleeding aggressively, profusely, not just bleeding. So the risk is real. These things are real, right? You fracture of the lingual plate in the anterior mandible, you nip an artery, patient will bleed, hematoma will develop, you know, he will get up a tongue obstruction and they will die. They will literally die. There is a case. So we really need to know, we need to always keep reminding, keep our mind active of what other drugs can have these things, right? With AFib as well, right? You've mentioned a lot of things about your physical exam and everything like that. But Imagine again that you don't have anything and you're primitive. All the civilization has disappeared. What is a small examination that you can do that can immediately, can fast let you know, or just that there is something wrong going on?
With the cardiovascular system?
With AFib.
History taking?
In your examination. So you don't have any access to any civilization. So how do we check the vitals? What are the vitals?
Heart rate.
Right. So how do you measure the heart rate?
Check the pulse.
Radial pulse, right? So what are you supposed to see in a patient who is got an AFib?
It would be erratic. It wouldn't be.
Erratic is not a word. Give me two words. Give me two words.
The heartbeat would be much faster.
Give me two words. It will be irregularly irregular, right?
Okay.
Irregularly irregular. That means you can have regular, or you can have boom, 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 right? Or you can have irregularly regular. You can have boom, 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 boom. I know. And then you can have irregularly irregular. You can have bum 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 bum, right? So you can have irregularly irregular, right? And it will be irregularly irregular for real, and you can always feel it, and it will be like, and that is the alarm. That's, of course, you know, if civilization finished and we have no access to everything else, no ECGs in the world and everything like that, you should really know it, right? So is there any type of blood thinners that we give to those patients? Apart from Coumadin, we can give them the new category of drugs, right? The Aliquis, the Xareltas, Protexas, right?
Okay, yes.
Correct? And they work into factor 10A, right? And why do we give them? Because they don't have the same drug interactions that Coumadin has, right? So the patient can live a normal life. One thing as well that you really need to know about Coumadin or warfarin is that the patient as well, food-wise, there's things in food-wise that can actually affect that drug, right?
Yeah.
So things like what? Like greeneries, like lettuce, right? Grapefruit juice, right? Who doesn't drink grapefruit juice, right? Things like that, right? So it can affect up, you know, it can affect all that. So these are the things that you really need to know, okay? It's very important, all right? But all in all, Amin, amazing job. Is Fatima here? Not Fatima, my assistant. Fatima, Dr. Fatima, is she in with us or not?
Hello.
Hey, Dr. Fatima is here as well?
Hi.
Hi. Is your dad working? Is your dad with us?
No, he's working.
Oh my gosh. Okay, good. So, okay. All right. So, are you going to be doing the other one or what's going on?
Yeah, the drug interactions.
Yes.
I already did that. I can repeat
Okay,
it for
perfect.
you.
Oh no, don't repeat it for me, if everybody, because I think now we can open the door for questions. So if you can kindly, if anybody has a question, they can just type it, and you know, Dr. Amin will gladly answer it, right? Or Dr. Fatima.
Yes.
I'm there for you, Dr. Amin. Don't worry. Don't worry.
Thank you.
There is a question there. Can you see it, Dr. Amin, down in the chat?
So
You want to add?
yes, because metronidazole is a
Can you be very specific about what type of anticoagulants?
No, I definitely don't.
to
No, I have no interest in getting in on this.
So anticoagulant is a very loose term, Dr. Hussein. Is that Dr. Hussein? It's very loose term, Okay, you have to be specific of what category of anticoagulants. Yes, Coumadin, warfarin. Yes, it increases. Yes, of course it is.
Is this the live thing? Are you doing a question thing right now? Is this the question answer?
But people are asking questions.
Oh, you just causing him trouble right now? With the...
Nah. Any other questions, guys? Who's RH? Is that Riham? Rabia, how you doing, Rabia? I miss you. Okay, so the BB guidelines and geriatrics and obese patients. You know what? A blood pressure is a blood pressure, and a blood pressure, you know, if you think about it, when you have a higher blood pressure, you're at higher risk. So here's the issue. But I understand that there is right now a lot of people are talking about the diseases of the geriatric patients, and that how we start to the definition of who have got truly a blood pressure and who doesn't have a truly blood pressure changes. The truthfulness of the situation, if somebody, regardless of how old he is, have 180 over 100, he's still in danger. Am I gonna ask myself a question? Have I not treated somebody who is 180 over 100? Yes. But those patients who are got serious kidney failure, do you think their blood pressure is gonna be low? Of course not, but they live in that territory. They're living with it on a daily basis. They walk around. I think the best thing to always figure out is that for you at this certain level, how comfortable you are with doing certain procedures. So, you know, if a patient is going through dialysis, his blood pressure is always going to be high. You're always going to see him at 180 over 105, right? Are you not going to treat him? Of course you're going to treat him, but will you be the person who treated him, or do you prefer to send him to someone, right? So the issue over here is that the true identification, right? Another thing that I want to draw the attention of everybody, if somebody's blood pressure is high, right? Always remember that he will be at an increased risk of bleeding, right? Increased risk of bleeding. Another thing as well, when you have an obese patient, remember that the cuff size has got to do a lot with false reporting, right? So there are certain things like this always in the back of your head. I hope that helps, Rabia. It's just that it's just that how how we can do it or how we couldn't do it. Can you do it? The question is that the guidelines, for example, for the INR that Dr. Ahmed has mentioned, she mentioned something that I think maybe could have modified a little bit. So when you say 2 to 4 is normal, 2 to 4 is not normal. 2 to 4 is, the normal is 1, but 2 to 4 is treatment is accepted, right? And some people say even 3.5. I think the NICE guidelines, I don't have anything in North America that can reflect to that, but I think we all follow up the what we call the National Institute of Excellence in Health, which is called the NICE guideline, which is an English thing, and they say up to 3.5 is acceptable. Up to 3.5 is acceptable. Now, some people might even push the envelope a little bit and say 4 is acceptable. But you have to understand something as well from this perspective, is that it's acceptable, but it's not normal. All right, so it's not normal. The normal INR should actually be 1 to 1.25, right? That's the actual normal INR. When you go up to 4, you're at a higher risk to bleed, right? And remember, what are you doing? All right, are you removing a wisdom tooth that is very close to the inferior alveolar canal, that you may sever up the inferior alveolar artery? Please don't do it when it's 4. Or are you just simply taking up tooth number 1, 2, that it's mobile and it's just going to come out by itself? Then that's something else, right? So totally 2 different issues. Any other questions?
Actually, I have a question, Dr. Hassan.
Listening.
So I had a patient actually. I think I was talking to you about this before, but we were interrupted. When I took his blood pressure, it was ranging from systolic, diastolic, like sometimes even over 180 and over 110, and sometimes lower, like 170 over 100 and 106. Then I did control on myself and my staff members. It was totally fine, but for him it kept varying. He was asymptomatic, said he knows he has high blood pressure, but didn't go to GP yet to consult. Just to be safe, I sent him to emergency to get checked out.
Absolutely.
What is the reason as to why did it keep varying like that? What could have been?
I didn't see a lot of variation. You told me it was 180 over 110 and then 170 over 106.
And sometimes even like 160 over 90.
You know what? I don't see a lot of variation. It's pretty high, right? It's pretty high. Did you try different arms?
Yeah, so I did myself and my assistant. And
No, different arms for the patient.
no, I didn't.
Right. So you know what? It is high. My only thing is the cuff size. Sometimes the cuff size can give you false reporting. Right? Was he a little bit overweight?
No, he was healthy.
All right. So as you know, patients could have a high blood pressure and he could be on drugs as well. Right? So just remember that.
Okay.
But it's a good thing that you sent him to the ER. It's actually the right thing to do. You don't want to mess around.
Even if they have intense pain, because on the other hand, I kept thinking, okay, he had like an infection. It's severe pain for a long amount of time. It's going to increase his blood pressure even more.
You can definitely give him some painkillers, which reminds me, what type of pain? If somebody has hypertension and he takes hypertensive drugs, what type of painkiller you want to avoid? You want to avoid ibuprofen, right? NSAIDs, correct?
Yes.
Okay, okay. Carry on.
That's all. Thank you.
And if somebody's taking a statin, what do you want to avoid? What type of painkiller you want to avoid? You want to avoid ibuprofen as well. That's easy to remember, right?
Yes.
Muscle pains, muscle aches, spasms, right?
Yes.
Okay. Anyways, so I hope that was useful. I know Dr. Sally has messaged me, said she had to leave, but I really thank you for your attendance. And I really apologize for joining late, but I promise you I was working and I'm still at the office. Okay? So God bless you all for being there for us. And hopefully, has Dr. Sally, what are we doing next time, Fatima? As Fatima,
Dr. Sally had to leave the chat, but
what are we doing next
she
time?
hasn't given me the next. She's holding me in suspense. She hasn't given me the next.
All right. Well, why
our
don't
next episode.
we nominate the person that is going to do the lecture? So why don't we let Dr. Rabia do something for us? How about that? Dr. Rabia, you're on. Dr. RH, one of my favorite, by the way. So
okay, well, he gave you a happy face. I think that means that's a go.
So we'll get Dr. Sally to give you the topic.